Good morning. I want to thank the organizers for allowing me to come here and present. And we've heard a lot today already. I'm going to try to stick to the clinician's perspective. We certainly have heard in vivid detail how patients are affected by numeracy issues. I first got interested in numeracy, I suppose, because I used to be a math teacher, and I began to think about these things. We've heard a lot of definitions of numeracy, but one of the things I think that the other speakers have talked about is how many different procedures are involved when we think about numeracy. And you've mentioned a hierarchy of skills that was in one of my papers that I'll show you subsequently. But the hierarchy comes from a paper by Goldbeck. And what she did was she organized the categories in or overlapping, but roughly in terms of difficulty. And I think it's important because it also gives you the whole broad picture of the numeracy concepts involved. So the first group was called basic, which talked about only the ability to identify and read numbers, which corresponds to the literacy tests that also have been displayed earlier. Then the next category she described was computational skills, the ability to do counting and arithmetic procedures. More difficult are analytic skills, inference, estimation, proportion, percentage, frequencies, basic graphs. I think these play a role vividly in our directions to patients in healthcare, and we often don't think about them, and they're the ability to interpret the information. And then finally, statistical skills, probability statistics, error, risk, which allow us to compare things, which allow us to understand probability, also very important concepts as we understand health. And of course, all of chronic care, and I'm going to be talking about that a lot, is based on trying to inform patients about prevention and risk, which is about probability and statistics. So this is the paper if you'd like to go see it. And patients encounter these concepts when they receive, follow, and pay for medical care. So thinking about managing a chronic disease, and Rima gave me this information and slide earlier. She didn't give me the slide, I'm responsible for that, but for the concepts. When I think about if a patient coming in to see me, I'm an asthma specialist or I'm an allergist immunologist, so I care for a lot of patients with asthma, see them over and over with a chronic disease, but it's applicable to other chronic diseases like monitoring blood pressure, like diabetes, and somebody has mentioned how important numeracy figures in the management of diabetes. The first thing that patients have to understand is perhaps the disease versus the symptoms, and understand frequency and how frequency can change trends, increases in severity. That's a numerical concept. They have to participate in the development of a management plan, which involves, as we already heard from Terry Davis, how hard that can be, and follow the plan. And again, I can't underline how important that is. Monitor symptoms. They may have to use measurement devices and record readings. For example, in my world, they might have to use a peak flow meter, or they might have to take their blood pressure reading, or they might have to measure glucose and understand what it means. And note changes in status, and most importantly, they have to present their history to the patient, to the clinician, and then have to understand the communication. So when I think of a patient's visit, I just sort of thought of the first thing the patient might have to do is present and have to present a copay. And then they might be taken into a room where their vital signs are taken. That's blood pressure, pulse, and weight and other skills. And when you think about it, patients have to understand what's a normal blood pressure. Patients have to understand what's a range. They have to understand the trends. They have to understand variability. And they have to understand errors in taking the medication, in the reading. All of these are difficult and require significant numeracy skills. In my world, they might have spirometry. That is a measure of how patients blow into a tube, and it measures how their rate of exhaling, which is a measure of asthma. And they would, again, have to understand these same sorts of values, variation, what's normal, what's best for them, trends. And then they have to talk with the physician and and talk about frequency and comorbidities and the context of their lives. And then there has to be a discussion, again, about risk and prevention and advice. And in the end, medications, and maybe in my world, an action plan. And here's an action plan. It can be a daunting experience. In fact, I don't always give it to patients, but this action plan is what to do with asthma. I don't know if there's a pointer. When it's formatted after a traffic light, so green, keep going, doing well; orange, caution, things are getting worse; red, you're in trouble, do something. And you can see as you look across that medicines have to be recorded and much to take it. That might be just at the very basic level, but there might be frequencies involved. So it might also involve analytic skills. Is there a pointer here? I don't see it. So at the top, you can see that there's, they ask what your best peak flow is and to record it. The peak flow is what you get over. See here, if you look up there. Okay. So they might ask you to write down your peak flow, but they might ask you to understand what 80% of your best is, or they might ask you to understand if you're between 50 or 79 of your personal best. So you have to understand the personal best, and then you have to understand these very complicated concepts. And Terry already mentioned when you're discharged from the hospital, it can be another daunting experience. For example, for this man who was hospitalized with an exacerbation of chronic bronchitis and was given a pill bottle containing prednisone tablets, each 5 milligrams, and told to take 30 milligrams. Not the easiest thing to understand always. Or this woman who, again, back to peak flows, because I'm going to return to that example. This is a peak flow meter. You're supposed to blow into the tube and get a certain number. And a physician or clinician may ask the patient to graph the results, thus understanding frequency and trends and stuff like that, but may not have the skills to do that and come up with something like this. By the way, you still see the green light, yellow light, red light here. Cancer patients may be confronted with the standard gamble. This was a concept to help patients and clinicians talk about preferences in care. A cancer patient is asked to give preferences for treatment by stating whether she would rather remain in a state of ill health for a period of time or undergo a medical intervention which has a chance of either restoring perfect health or killing her. Time trade-off is another such example, and you can see how difficult it is to understand these concepts and then to use it for making health choices. And this is all in the context of what you heard earlier, that Americans have more than 50% have no more than the most basic quantitative skills. So we did a little bit of research on this. This is not something we did to patients. It was research, but to try to understand what of the asthma skills patients understood. So we asked them, we found 4 questions that are common concepts in the National Asthma Guidelines, and we made it in English and Spanish, and we read it to patients and showed them the question as well, so that we were trying to talk about numeracy, although they still had to comprehend. And we asked this question, here's the prednisone question again. And when we asked patients, 84%, these were patients with moderate or severe asthma, 84% did get it correct, but that means that 16% didn't understand. The next question we asked was about risk and percentage. Osteoporosis is a risk that one could get from taking steroids for a prolonged time, and that's what is often prescribed in asthma. And trying to go forward here. So most patients did not understand what 1% meant. Then we asked a peak flow question, like the peak flow meter I just showed you, asked what's 50% of your personal best if it's 400 liters. And while almost 3/4 of patients got it right, more than a quarter got it wrong. And then finally, this was to improve the psychometrics of the test, the variability of the test. We asked a more complicated peak flow question, and it was totally confusing to patients. What's interesting is when we compared these numeracy questions to another test of reading comprehension, the short test of functional health literacy in adults, there was a correlation between the two, but only moderate correlation. That's interesting, why the correlation is not more. It could be for a lot of reasons. It could be because numeracy is just very different from reading comprehension. It could be that the test characteristics are very different, which I think they are. And it could be that the asthma questions these were asthma patients, were more on the context of asthma, where the reading comprehension content was not surrounding asthma. But what's even more important than that was that we found that patients who got low scores on the numeracy questionnaire, low scores were associated with more hospitalizations and ED visits for asthma. We didn't see that in the reading comprehension test. But we also saw that this over time too, when we monitored patients for asthma in terms of asthma control. A lower score means better control. This is a spirometry score. Higher score is better. And quality of life, higher score is better. And we were also monitoring adherence, that the patients with higher literacy always ended up on top. So what this shows is that it seems that patients, that numeracy concepts are difficult for patients and that they're associated with lower health. And that link is what's really important. So if they exist and associated with poorer health, what should we do? As a society, of course, I think we have to make sure that the educational opportunities are equal for all people and adequate. For patients, as Terry already talked about, we have to demand concepts that we can understand, but I'm here to talk to you about what clinicians can do. And I would suggest that maybe if we organize our thoughts into two areas, that might be helpful. One is to decrease the demand of the numerical concepts, and the other is to increase the communication skills. So to decrease the numerical demand, that's what Dr. Peters referred to earlier. We made this matrix, and what we did was we, on the left, on the y-axis, you might say, we ordered numerical concepts by difficulty, roughly according to Goldbeck's groupings, and using concepts that are often used in treatment of asthma or health in general. So you see reading numbers is on the top, and things like risk perception is on the bottom. And then on the horizontal axis, we organized the level of mastery required in the communication. So descriptive information is the easiest to understand, and then interpreting, and then finally making decision-making. And then what we hypothesized was that if you could move a communication, I don't know where it went. If you moved a communication upwards and to the left, that might simplify the communication. So for example, the prednisone question, you're given five milligram tablets, how many should you take? Instead of asking it that way, which is problem solving and percentage and decision making, so over here on the right, instead you just said take 6 pills in the morning, you would move the communication upwards and to the left. If a doctor says to a patient, if you lose 15% of your weight, you will improve your health, 10% of your weight, you can improve your health. If instead they say lose 5 pounds, you're moving the communication upward and to the left. If instead of saying take a medication twice a day, you talk to the patient and understand the concept and say take it when you get up and take it after school, or something like that after work, you've moved the communication up and to the left. If you're interested in talking about trends, if you're a diabetes patient and your doctor wants to know the trends and how you're reading, and is instead of having to write down to calculate error and things like that, instead you graph the information for the patient. You've moved the discussion upward and to the left. I think others will talk more about other ways to do that, including framing how you package and present the information. So for example, going back to the prednisone example, if instead of talking about prednisone pills, to put that in a different context, that 5 milligram pills are like nickels, and talk about making a comparison with change, that may be helpful. It's important to know that framing needs to be appropriate. So for example, patients and even physicians are known to make different interpretations when you make a statement like, if you have this chemotherapy, there's a 70% chance that you will die, versus if you have this chemotherapy, there's a 30% chance that you will live. People, all sorts of people make different decisions, so the framing has to be appropriate. Visual aids, somebody already mentioned having more than one format of presenting the information is important, and using graphs is important, and I know Dr. Anker will talk more about that, and using the appropriate graph at the appropriate time. So for example, if you're talking about a trend, you may want to use a line. This is actually patient's symptoms over time. Or if you're making a comparison part versus whole, you might want a pie chart. Or if you're making other comparisons, you might want to use a histogram. The other thing that I think that clinicians can focus on is communication. Dr. Peters wrote an article that I admire called "Less is More." So keeping the information to the very minimum, most essential, and removing non-essential information is important. Rima's taught me that plain language and not doctor language is important. There are other techniques you can do. For example, Rima wrote a paper about you could list possibilities for patients, what to do if, and be very concrete about what the different alternatives are. Most important for clinicians, and we have very little time to do that, is to conduct a teach back to try to understand, to be sure we confirm understanding by patients. Several of you have mentioned the patient advocate, or actually you've mentioned patient navigators that are being used to try to help patients navigate the health system. We've been doing a little work with a patient advocate. We call them a patient advocate because the patients we had focus groups of patients and asked what they should be called, and they said an advocate. And our advocate is like having a very good family member come to a medical visit with you. So the patient advocate would help the patient focus down on 1 or 2 points that they might want to cover in the interview, sit in on the interview, teach back with the interview, and if the patient advocate heard something different than what the patient heard, refer the patient and the clinician back to each other. So that sounds like a very resource consuming idea, but parts of that can be used effectively in healthcare. And even those tasks can be distributed among the entire office. So there are all sorts of techniques to be explored to improve communication between clinicians and patients. Before I close, I just want to, and with apologies to the Institute of Medicine, to bring up that I think that we're rapidly needing training in another literacy skill, and that's electronic literacy. That becomes daunting literacy for some people, but it also has great potential for providing yet another format for presenting health information, and particularly numerical information. So here are the demands. There are significant unrecognized numeracy demands for adults with chronic diseases. I guess we've recognized that, though, today. That poor numeracy is associated with poor health outcomes. and that limited numeracy can impair the ability to communicate and understand health information, such as shared decision-making. And so challenges are that it's essential to equalize and enhance educational opportunities. I can't stress that enough. And we have to understand how to account for limited educational opportunities and limited numeracy in our patients so that there's adequate access to healthcare and effective communication. I think electronic literacy is something that's becoming increasingly important and important to harness. And we need research to explore the best ways to account for numeracy in improving healthcare. So, thank you.